morning, everyone. My apologies for starting late, but there was a technical problem on the e-learning websites. I couldn't create a Microsoft Teams meeting link. I went back to the old platform, which is the one for the dental anesthesia course, temporarily, just to make this lecture going on, and then maybe next lecture we can resolve these technical issues. This lecture is one of the maybe 2 or 3 series of lecture about management of impacted teeth. And when we talk about impacted teeth, we mainly talk about wisdom teeth. So let's start by defining impacted teeth. Impacted tooth is the tooth that fails to fully erupt into the dental arch within the usual range of expected time. We call it impacted tooth. So if it is within the usual range of if it exceeds the usual range of erupted time, then this impacted tooth. If it's within the eruption time, then this is unerupted tooth. It's not yet impacted. So there are many causes for tooth impaction. The most important one is the abnormal tooth orientation. That means the tooth bud during tooth development displaced or got wrong orientation in relation to the surrounding structure and surrounding teeth. So this may cause later on difficulty in erupting of this tooth and impaction at the end. Also, adjacent teeth may take the space of that tooth and make no space for that tooth to erupt. So this tooth will stay impacted within the bone. Other conditions, the problem is with the overlying tissues, such as the hard tissues like bone. In some medical conditions, there is very dense overlying bone that make tooth eruption very difficult or impossible, like let's say bone metabolism problems like Paget's disease or bone petrosis. Sometimes the problem is with the soft tissue, like marble bone disease. Sometimes the problem with the soft tissues, like having excessive soft tissue in the area of the tooth where the tooth must erupt. So excessive soft tissue in that area, scar, dense soft tissues, like cases like fibromatosis, may impede this tooth eruption. Other causes of tooth impaction is the genetic abnormality. And from pediatric dentistry course and oral pathology, there are several conditions that cause teeth impactions and delayed eruptions. You need to know them. And another important factor that may cause tooth impaction is the inadequate dental arch length and space. And in case of wisdom teeth, we mainly talk here about retromolar area for the lower mandibular wisdom tooth. Okay. So the most common impacted teeth are number 1, maxillary and mandibular third molars, and the reason is obvious. They are the last teeth to erupt in the arch. Sometimes there is no space for them to erupt, so they stay impacted. The second most common are the maxillary canines, also for the same reason. We know that the maxillary canines erupt after the eruption of the upper lateral incisor and upper first premolar. Sometimes the upper lateral incisor and upper first premolar took the place or the space of these canines. So these canines may be impacted either buccally or palatally. The third common impactions are the mandibular premolars, and for the same reasons, these are the last teeth to erupt in the mandibular arch, apart from the third molar, of course, because the lower canine and the lower molar erupts before them, so they may take their space. Most commonly here, we're talking about the lower second premolar. So, generally speaking, all impacted teeth should be removed unless removal is contraindicated. And the reason why we need to remove all these impacted teeth, because with advancing age, the removal of them will be more difficult. And as they stay for a long time impacted in the jaw, they may cause some local tissue morbidity around them. And if we decide to remove them in advanced age, the removal will not be that easy, and there'll be lots of complications, and it will be complicated extractions, and post-operative complications will be more. Impacted third molars, which is the main topic of this lecture. We know that the average age for completion of normal eruption of third molar is 20 years. So it's between, let's say, between 17 years to 21 years, but it may erupt as early as 14-year-old in some population, and may erupt late at the age of 27 or 28, especially in European population. But the mean age of eruption is around 20. Eruption may continue in some patients. This is called late eruption. It may continue till age 25 or 26, 27. During the normal development of the third molar, the tooth bud begins in a horizontal angulation. And as the tooth develops and the jaw grows, the angulation changes from horizontal, then to mesioangular, then to vertical. If a problem happens in this change in angulation or rotation from the mesioangular to the vertical direction, this will cause third molar impaction. And this is the most important, as we mentioned earlier, this is the most important factor in third molar impaction, which is the abnormal orientation. Also, sufficient space needs to exist between the anterior border between the interior border of the ramus and the second molar to allow eruption. If there is no sufficient space, then failure of eruption or impaction will happen. And the problem here is with the people that have a small jaw, they don't have enough space for the lower third molar to erupt. And with a new, let's say, with a change in diet of human beings, where the diet become less coarse, more soft, it reduces the interproximal attrosions that cause back teeth or posterior teeth to move mesially. This used to create a space for the posterior teeth to erupt, especially lower third molar. When this mesial movement is not happened due to the change in diet of modern, let's say, modern human being, then no space will be created at the back of the mouth in the retromolar region. So this will create no sufficient space for the lower third molar to erupt. So this is one of the theories behind impaction of lower third molar. What are the advantages of early removal of impacted teeth in general, especially lower third molars? This will reduce the post-operative morbidity and allows for best healing. Why this is reduced post-operative morbidity? Because we know that younger patients tolerate surgical procedure better, recover more quickly, and this interfere less with their daily lives. Also, in younger patient, periodontal healing is better. So this will affect the bone regeneration and the regeneration of periodontal tissues and the distal aspect of the lower second molar after removal of the impacted third molar. In case nerve injury happened after third molar surgery, nerve repair, or let's say nerve healing, would be better, and a prognosis is better in this case. Also, procedure will be more straightforward if we perform it in young patients, because the bone is less dense compared to older population, and the root formation for younger patient is incomplete. So this makes things or surgical procedure easier. I'm going to talk about in detail about this in details later on this lecture. So, what's the ideal time for removal impacted third molar? If you want to look at the root formation, it's between when the roots are formed between 1/3 and 2/3. So this is the ideal time to remove it, as you will have easier extraction based on the difficulty factors that we mentioned earlier. Also, if you look at the age of the patient, the ideal time is removed is between mid to late teenager. That means after age 16 up to age 20. This is the ideal time to remove third molars. Now, let's talk about the indications for removal of impacted teeth in general, and especially for wisdom teeth. One of the most important indication is to prevent periodontal disease. We know that presence of impacted mandibular third molar will affect the distal aspect of the adjacent second molar by decrease the amount of bone distal to the lower second molar. Also, it's very difficult if there's a pocket distal to the lower second molar to keep it clean. This may result in gingival inflammation, and this will result also in apical migration of the gingival attachment, then periodontitis or periodontal disease at the area. The problem here will be more serious if it happens in the maxilla, as it may involve the distal forcal area of the maxillary second molar. And we know that distal forcal area of the second maxillary molar is a bit coronal to the other forcal area, so it's very easy to be involved in any periodontal problem. So the loss of attachment will be rapid and severe and difficult to treat. So if we remove this third molar early, periodontal disease could be prevented, and the likelihood of bone healing and bone fill in that area will be increased, the area that's previously occupied by the crown of the lower or by the third molar. So here is an example, few examples of periodontal problem arise from impacted third molar. We can see here at the top left, the pockets between the lower impacted third molar and the adjacent septum was very difficult to clean if food gets in there. So this will cause bone resorption and loss of attachment. And this may become more severe, okay, as you can see in the right hand picture here, in the right hand side. As you can see, the apical migration reach also to the top of the root of the adjacent second molar. Same things here for the bottom left one. And in some cases, these periodontal problems is irreversible and the bone loss is irreversible. You'll end up having not only the third molar extracted, but also the second molar extracted. So the prognosis here for the lower second molar will be poor if we left this lower wisdom for a long time to cause this problem. Another indication for removal of impacted wisdom teeth is prevention of dental caries, either in the impacted tooth itself or the adjacent tooth. And we know the area is not easy to clean, distal to the lower second molar when there is impacted third molar there. So this will cause a decay in the area, and this decay may reach the pulp and may reach also the root, and sometimes the tooth deemed unrestorable, and you may end up extracting both teeth, the second molar and the third molar. So it's very important to consider this as one of the indications for removal of impacted third molar. Also, if you look at the picture here in the in the right side here and in the middle, you can see the decay here in the septum. You can't treat this decay unless you extract the third molar. So you have to extract third molar first, and then do the restoration or the maybe the let's say the root canal treatment or the pulpal treatment for the adjacent second molar, and you may end up also having crowning this second molar because of the extensive coronal structure loss. Another important indication for removal of impacted wisdom teeth is to prevent pericoronitis, and pericoronitis is the most common let's say, acute pathology associated with impacted wisdom teeth. So we need to understand this condition and how to manage this condition. What we mean by pericoronitis is the infection of the soft tissue around the crown of the partially impacted tooth. As you can see here in the picture, in the bottom right in the slide here, you can see there's a soft tissue covering the crown of, or the, let's say, the impacted tooth or the unerupted tooth. This part of or this piece of soft tissue, we call it operculum. If it gets inflamed, the condition will result in pericoronitis, which is inflammation of this operculum. And this inflammation is, or this infection is caused by the normal oral flora. Most of the time, we know that there is a balance between the bacteria and the host defense. Okay, the bacteria is there, the host defense is there, but there is no problems because of this balance. But this balance may sometimes compromise if the host defense become compromised. So if patients suffer from, let's say, a flu or any upper respiratory tract infection, or start taking immune-compromised medication. So this may cause this balance to be lost, and then infection at that area might happen from the normal oral flora, and this will result in pericoronitis. Another cause is the repeated trauma from opposing or impinging upper maxillary third molar. This may result in pericoronitis. Another cause is food entrapment in under the operculum, and the difficulty in getting rid of these food debris and cleaning the area will result also in pericoronitis. So what are the most common organisms causing this infection? The streptococci and another anaerobic bacteria. Usually these are the same bacteria that cause periodontitis, like Echinella, Treponema, and other anaerobic species. So these are the organisms involved in pericoronitis. So this is an example of clinical case of pericoronitis. The right-hand side, you can see here, partially erupted wisdom tooth, and there is an inflamed, swollen operculum around it, covering the distal side, with, let's say, minor ulcerations in this operculum. This is most probably consistent with impinging upper third molar biting on this operculum, causing this inflammation. In the left-hand side, you can see the inflamed swollen operculum also at the distal aspect of the lower third molar. And this problem, or maybe it's covering the whole third molar, which could be soft tissue impacted. It may arise from problem in the, as we mentioned earlier, losing the balance between the host defense and the oral flora, or could be from the food accumulation and the distal aspect of the lower second molar, and difficulty in cleaning this area. So, in order to prevent pericoronitis, easy thing is to extract that third molar before it happens. But if it happened, how do you manage it? The management depends on the severity, because it may be mild, severe, mild pericoronitis, could be moderate, could be severe and aggressive pericoronitis. In very mild form, or the mildest form, patients may suffer from localized tissue swelling and soreness only, without any other problem. So the only problem is just like tenderness in the area with a little bit of localized swelling. In this case of mild infection, the treatment is to irrigate under the operculum and clean any food debris there by doing curettage. This could be done by the dentist, and you can send patient home with mouth rinses, and sometimes you provide patient with monojet syringe to irrigate under the operculum. Patient can use any mouthwashes or any solution that you use in the clinic, as we're gonna mention them now. So what you do is just provide patient with painkillers and debride the area mechanically, like doing for treatment of periodontitis and treating periodontal pockets. So you treat these pockets under the operculum. You can flush the area with either hydrogen peroxide chlorhexidine, which is antiseptic, iodophors, or just normal saline. All of them are effective. Sorry. Hydrogen peroxide has a superior advantage here that it's not only flush the area mechanically, but it is also, hydrogen peroxide, it can liberate oxygen in that anaerobic environment. So this will change the anaerobic environment a bit, make it more maybe aerobic. So that will affect the anaerobic bacteria in that area. It will provide two actions here. The hydrogen peroxide. Chlorhexidine is very effective antiseptic. I would consider it maybe the let's say the agent of choice here to irrigate with the chlorhexidine under the operculum and send patient with the chlorhexidine mouthwash to use twice a day. Each time rinse with chlorhexidine for 1 minute, and he can also use salty water or normal saline to flush under the operculum using monojet syringe. And of course, we have to provide patient with painkillers to relieve pain. If the pericarditis is a bit maybe let's say severe, and the amount of local soft tissue swelling is larger, and there is a signs of trauma from the upper maxillary third molar, then a good option here to immediately extract the upper third molar in addition to the local irrigation. So in this case, we remove the cause, which is the impinging upper third molar. As we mentioned, one of the important causes for pericarditis is impinging upper third molar. So if you extract the upper third molar, then you remove the cause, and you do also local irrigation, the area and under the operculum. If there is, if the patient presents with facial swelling, let's say mild facial swelling, with mild trismus, with limitation in mouth opening, with the result from inflammation that extended into the adjacent muscles of mastications, and patient has low-grade fever, then you consider treat the patient at systemic level. So you need to administer systemic antibiotic, of course, along with the irrigation of the operculum, and considering extraction once symptoms resolved, or extracting the upper wisdom tooth if the upper wisdom tooth is the cause. Your antibiotic of choice will be penicillin, so you can prescribe patient with amoxicillin, or maybe amoxicillin with the clavulanic acid, which is Amoxicillin or Augmentin, for 1 week course. If the patient, of course, not allergic to penicillin. If patient has an allergy to penicillin, you can prescribe clindamycin, but maybe the side effects here will be a bit more than penicillin. Some patients can't tolerate clindamycin, but it's also a good antibiotic to prescribe in a case of pericarditis. Of course, metronidazole, which is a flagyl, could be also used for treating pericarditis, as we mentioned earlier. Good percentage of the microorganisms involved in pericarditis are anaerobic bacteria. You need to know that pericarditis may lead to serious facial space infection, and this infection may spread rapidly into the facial spaces around the mandibular ramus and deeply in the neck. So in this case, you are dealing with facial space infection, and the signs will be trismus. There will be also high temperature, high-grade fever, above 38. There will be facial swelling. There will be severe pain, malaise. In this case, you need to refer patient to oral maxillofacial surgeon, the hospital, where we need to give parenteral antibiotic and monitor the patient and schedule patient for maybe incision and drainage if needed, plus extraction of the tooth. When you have patient presented with pericarditis, you should inform the patient that this tooth should be removed at the earliest possible time. when symptoms and signs resolve to prevent recurrent infection or recurrent pericoronitis. We advise not to remove the lower third molar while the pericoronitis is active. So you have to wait till signs and symptoms of pericoronitis completely resolved. As if you removed the tooth while the signs and symptoms of pericoronitis is still there, you may have more post-operative complication, especially dry socket, and this could lead to post-operative infection that spread and cause also fascial space infection. These complications increase in case the tooth is removed during the time of active soft tissue infection. And this is very important here. We know that pericoronitis is an infection, and also there is another source of odontogenic infection, which could be the pulpal source of a tooth. If the problem is within the pulp, not within the soft tissue or the periodontium, it's advisable to remove the tooth, which is the cause here of the problem. You remove the tooth, or you do, let's say, a root canal treatment or pulp treatment for that offending tooth, because the problem is with the pulp. But here, because the problem is within the soft tissues, the problem here is not in the tooth itself, it's the soft tissue surrounding it. So it's not advisable to extract the tooth while the active infection is going on in the soft tissues. Because later on, when you come to the lectures of odontogenic infection, the first line treatment is to remove the cause, which is extract the tooth. But the story here is different. For pericoronitis, we don't advise to extract the tooth. We advise to manage the case, irrigation, medical treatment. Once symptoms and signs resolve, then you extract the tooth later on. Also, if you extract the tooth while active pericoronitis there, you expect more bleeding because it's inflamed tissues. So it will bleed a lot, and the healing will be slower in this case too. Okay, so how to prevent pericoronitis? The ideal way to prevent pericoronitis is to remove this impacted third molar before it penetrates the oral mucosa and become visible inside the mouth. Another alternative options is to do a procedure called operculectomy, which is removal of this operculum. So you remove these operculums, soft tissue procedure. Could be done using a scalpel, could be done using laser. However, it's a painful procedure afterward, let's say. Usually ineffective. You end up having this operculum regrowing again over the impacted third molar. And you don't resolve here the problem of pocket at the distal aspect of the second molar. And it's not effective in certain impactions or certain types of impaction of third molars, like horizontal impactions, because, or the mesioangular, because they still have these deep pocket, the distal aspect of the lower third molar. So it's not routinely used to prevent pericoronitis. Another major indication for extraction of impacted wisdom teeth is to remove or to prevent, the root resorption of the adjacent tooth. We know sometimes impacted tooth may cause sufficient pressure on the root of the adjacent tooth. This may cause external root resorption, similar to the resorption process that goes to the primary teeth by the underlying succedaneous teeth. So if you remove this impacted tooth earlier, this may result in salvage of this adjacent tooth by cemental repair of these minor defects caused by this impacted tooth. You need to keep in mind that sometimes when this root resorption happened and you remove the wisdom tooth, it may reach the pulp, so the adjacent tooth need to be treated also endodontically in order to be saved. This is an example of root resorption of teeth caused by impacted teeth. In the right-hand side, the impacted wisdom tooth causing root resorption of the adjacent lower 7. As I mentioned earlier, sometimes the resorption is too severe or too deep that you can't save this tooth, so you end up extracting the lower second molar in addition to the lower third molar. Left-hand side, you can see here an upper impacted canine causing resorption of the roots of the lateral incisor, upper lateral incisor. Of course, you need to extract this upper lateral incisor and let this upper canine to erupt. Another main indication for removal of impacted teeth, if these impacted teeth under dental prosthesis. We know that sometimes you fabricate denture for patients. Patients have impacted tooth. Tooth is completely impacted within bone, but with time, bone resorb and the ridge resorb, and then the impacted tooth become superficial, become soft tissue impacted, not bony impacted. So this denture may start compressing the soft tissue overlying the impacted tooth. This may result in ulceration of this overlying soft tissues, and this may initiate odontogenic infection. So better approach is to remove these impacted teeth if possible before prosthesis is constructed. If we leave them and consider extraction later on, removing them may affect the prosthesis. The prosthesis may not fit because there's sometimes when we extract these teeth, we need to remove bone, so you may alter the alveolar ridge shape and the prosthesis becomes less functional, so you need to redo it again. Also, when this prosthesis start compressing the soft tissues overlying this impacted tooth, it may cause ulceration with infection. And if you remove, this will create, of course, unfavorable situation for extraction. If you carry out the extraction, this will lead to delayed healing and increase the risk of wound infection also at the extraction site after the procedure. Another thing, if you postpone the extraction till patient become older, as we mentioned earlier, the poorer health of this patient may result in delayed healing and more complication. And very common scenario when ridge resorb to a severe extent, it may become atrophic, like atrophic mandible. If you extract tooth with an atrophic mandible, there is a high chance to fracture this mandible during extraction. Very important thing, if you are planning to place implants near to the area of impacted tooth, it's better to remove this impacted tooth before you place implant. So this impacted tooth doesn't interfere with implantation procedure or cause a problem to your implants later on or in the future. So here are a few examples of impacted wisdom tooth that sometimes become no longer impacted and erupted. So start causing problem and pain for patient wearing the denture. As you see here in the right-hand side, the impacted tooth starts causing problem. One of the abutment teeth that carrying this bridge or holding this bridge. So you may lose this abutment tooth, and at the end, you're gonna lose the whole bridge here. So it was clever or very good idea to remove this wisdom tooth before start doing this prosthesis. Also, if you have atrophic mandible, like top left picture, if you start removing this tooth, you may end up fracturing this very thin mandible. Same as here in the bottom left side, you can see the impacted canine within the bone, within this mandible. If you remove this impacted canine, you may create a big bony defect and it may weaken the mandible and end up fracturing this mandible later on. Another important, let's say, indication for removal of impacted teeth is to prevent odontogenic cyst and tumor formations around them. We know that dental follicles around impacted teeth may undergo some cystic degeneration and become a dentigerous cyst. This is the common cyst of the maxillofacial region, maxillomandibular region. And if this cyst lived for a very long time, it may reach enormous size and weaken the bone of the mandible. So if you look at the radiograph and you look at the impacted tooth and you see the follicular space around the crown greater than 3 millimeter, then you need to consider diagnosis of dentigerous cyst here. So here are a few examples also of impacted tooth that cause the cyst to be formed. Sometimes we don't know, sometimes maybe the cyst starts before the wisdom tooth and it's not dentigerous cyst, but here, let's say that most probably these are dentigerous cysts. causing or formed around the impacted third molar. In the right-hand side, this picture could represent not odontogenic cyst only, odontogenic tumor. And the most common odontogenic tumor that may arise around impacted teeth is ameloblastoma. So you end up here having resection of this mandible along, so patient may lose a good amount of his mandible because of this impacted wisdom tooth. And simply also, let's say the one in the left-hand side here in the bottom, this dentigerous cyst, you need to marsupialize this cyst first, then allow the mandibular third molar to move a little bit forward, then extract the third molar. As if you try to remove this cyst, you may injure the inferior alveolar nerve. So we extract impacted teeth to prevent this from happening. Impacted teeth may be removed as part of treatment of pain of unexplained origin, especially if the pain is in the retromolar region of the mandible. Some patients may present with this pain in the retromolar region of the mandible. The wisdom tooth is completely impacted. There is no signs of infection there. Everything is okay, but patient still feeling pain. The only thing to blame there is that's impacted tooth. So you have to remove it and see afterward. Most patients may respond favorably to this extraction and this pain may go away. Also, some patients that present with myofascial pain dysfunction syndrome, which is a common orofacial pain syndrome or other facial pain disorders. If you try your best to resolve the problem, provide patient with every management option and
دكتور الصوت راح، حطيت ميوت.
sorry. Okay. Okay. Is it like just from this slide where I have the sound muted, or a few minutes ago?
بس هاي السلايد.
Okay, so maybe because this could be because of the WhatsApp connected to the laptop. Okay, sorry about that. Okay, so one of the indication for removal of bacterial wisdom teeth is treatment of pain of unexplained origin. Patient presented with pain, you tried everything, or facial pain, you do all your diagnosis stuff, give patients the available medications, tried, let's say, mouth guards, Botox injections, everything, and still patients feeling pain, not improving, and you have impacted tooth there, either impacted maxillary wisdom teeth or mandibular teeth, then put it as an option of treatment to extract this tooth. It may resolve the problem. Especially if patient presented with pain at the retromolar region of the mandible at the area of the lower wisdom tooth, and everything looks well on clinical examination, no signs of infection, no swelling, but patients feel pain there, just extract that tooth, that impacted tooth, and this may resolve the problem. Okay. Okay. Another indication for removal of wisdom teeth in certain people is to prevent the jaw fracture. The presence of wisdom tooth there weaken the bone, make it an area of weakness. So if patient get any trauma to that area, so it's very easy to get a fracture that pass through the area or the region of the lower third molar. I think this is done with certain types of sport where the people at high risk of getting mandibular fracture from maybe kicks or box. So in this case, the advice here is to prophylactically remove this lower wisdom tooth. Not to weaken the area or make the area render for fracture if we get a box there. Because the area is very weak while the lower third molar is there. Another indication for removal of wisdom teeth is to facilitate orthodontic treatment. Orthodontist may want to retract the lower second and lower first, let's say, upper or lower first or second molars by any orthodontic techniques. You need to create this space for the orthodontist. So you need to remove that impacted wisdom tooth. So the orthodontist can retract or distalize the first and second molar. Sometimes orthodontists want to use the area of our wisdom tooth for anchorage, for distal anchorage. So you need to remove this wisdom tooth, and he will put his TADS or any anchorage device in there to support the anchorage. So you have to remove this wisdom tooth before doing that. And of course, if you are planning orthognathic surgery for patient, and you'll be doing a mandibular procedure for this patient, like BSSO, it's advisable, or sometimes it's a must to remove these wisdom teeth at least 6 to 9 months before the procedure. This will make the cuts in at that area easier and avoid unfavorable fracture during the osteotomy. Okay, so let's talk here about also we mentioned earlier about preventing periodontal problems caused by impacted third molar or impacted teeth. So we are here looking at optimal periodontal healing. So if we talk about lower third molar, lower second molars, so there are two primary parameters of periodontal health after we remove the lower third molar from the area. These are the bone height and the periodontal attachment level, the PDL level, at the distal aspect of the second molar. And the most two important factors that affect these two parameters that will affect the periodontal healings are the extent of the preoperative infrabony defect at the distal aspect of the second molar before the surgery and the patient's age at the time of surgery. And the reason we mention this here, we need to look at the age of the patient. So the age of the patient is very important predictive factor in predicting the periodontal healing around the second molar after removal of impacted third molar. The recommendation here is asymptomatic, completely bony impacted third molar in any patient older than 30 years should probably be left in place, unless some specific pathological condition develops, like say cyst or fracture passing through this wisdom tooth or any pathological lesion. And the reason behind this recommendation is that patient age affects to great extent the periodontal healing after removal of that wisdom tooth. So the periodontal healing around this lower second molar will be affected by the patient age and by the bone resorption or the bony defect caused by this impacted third molar at the distal aspect of this lower second molar. So if you have a patient that has completely impacted third molar, bony impacted, we saying here bony impacted, that means this tooth is completely covered with bone and he's above age of 30, then just leave this tooth unless you have pathological condition arise on the area. A contraindication for removal of impacted teeth if the potential benefits or the risks outweigh the potential benefits of removing these impacted teeth. So when the risks are greater than the potential benefits, then this procedure should be deferred or abandoned. One of the contraindications is the extreme of age. So we don't remove wisdom teeth at very early stage, when the calcification start and the bud of the third molar start to form. Some may do what we call remove the germ of this lower third molar, germectomy. We don't do it. We're going to talk about it as one of the options for the treatment of lower impacted teeth that mentioned in the literature. And this happened at the age of 7 to 9 years, where the third molar buds start to form and they remove the bud before the roots start forming. So we don't do this, as this is You don't have the accurate diagnosis, this tooth could erupt in fully functional position without any problem and may not be impacted. Also, in the extreme elderly patients, we know as patient ages, bone become highly calcified, less flexible. So this bone will bend less under force of tooth extraction. So this will create difficulty in the extraction. And of course, patient will respond less favorably to a post-operative sequela. This will, less favorably to the extraction, and post-operative sequela will be more. Also, in the extreme age, if the tooth is there for ages, for too many years, not causing any periodontal problems, no caries, no cystic degeneration. So it's unlikely for these teeth to cause any problem later on. So why not? Why to remove this tooth? So just leave it in there. So another, let's say, a recommendation here: if you have patient who's older than 35 years and he has impacted tooth, completely bony impacted tooth, no signs of disease. Radiographically, you can detect bone all around the tooth. Then this tooth should not be removed. Just follow up radiographically every 1 to 2 years. Because as we mentioned earlier, most of the time, in most cases, this tooth will not cause any problem in the future. Okay. So this is an example here. This is a edentulous patient. You find here in the OPG, there is an impacted wisdom tooth. Maybe you can't see it, but if you look at the top left of this OPG, which is the upper right quadrant, you can see high impacted maxillary wisdom tooth, not causing any problem for the patient, completely surrounded by bone. So just leave it. There is no need to go after it and start digging the bone there to remove this wisdom tooth. So let's, broadly speaking, let's say the cut-off point for age is, it's better to remove this wisdom tooth before 25 year before 25-year-old, before patient become 25-year-old, before the age of 25. Later than 25, for each year after 25, you increase the chance of postoperative complications will be severe. Will also, you decrease the chance for periodontal healing. Periodontal healing is better before 25-year-old. So our advice is to remove wisdom teeth between 17 to 21 and up to 25 years. After 25 years of old, if there is no problems, completely bony impacted, then just leave this wisdom teeth in. Another contraindication is compromised medical status. So here, if patient is medically compromised, you don't have any symptoms from this wisdom tooth, then why to electively remove this wisdom tooth if not causing any problem? Just leave the tooth there. Then if this tooth start to be symptomatic, then you liaise with patient physician how to remove this wisdom tooth, maybe in hospital setting, in controlled outpatient setting. And so that's different story. Another contraindication, if removal of this wisdom tooth or impacted tooth, let's say in general, will cause excessive damage to adjacent structures. And here we're talking about nerve, mainly the inferior alveolar nerve, or adjacent teeth, or previously constructed bridges. So in this case, if this tooth is asymptomatic, just leave it in there. Don't remove this tooth. So in making a decision whether an impacted third molar should be removed, you need to consider a variety of factors. We talk here about young patient present to your clinic, wisdom teeth still erupting. You get consulted about these wisdom teeth, whether to leave or extract. So in treatment planning here, you consider these factors. Is there a room in the arch for this tooth to erupt or not? What's the status of this impacted tooth? Is it like, let's say, carious tooth? a healthy tooth without any problem. The angle of this tooth, is it favorable angle? The age of the patient. So you start to predict whether this tooth may erupt or not. Also, you need to consider the status of the adjacent second molar. Sometimes the second molar is, let's say, badly destroyed or heavily restored or decayed because of this impacted tooth or root resorption caused in there. So you may consider extracting this second molar and not the wisdom tooth. So you need to consider all these factors in mind when you treatment plan, treat patient for planning patient for lower wisdom teeth, either to extract or to leave. Now, the best thing in these cases is to follow a guidance if there is a guidance. And very common two guidance, let's say here in the wisdom teeth literature, are the UK guidelines and the American guidelines. For the UK guidelines, we are talking about the NICE guidance that was published on like 26 years ago in 2000. These guidelines stop the practice of prophylactic removal of pathology-free impacted third molars in the UK by the NHS doctors. So they say that the routine practice of removing pathology-free impacted third molar should be discontinued. And the removal of these wisdom teeth should be limited to the teeth with evidence of pathology. And this pathology could include unrestorable caries, pulpal involvement, periapical pathology, cellulitis, abscess, osteomyelitis, resorption of the roots of the impacted tooth or the adjacent tooth, fracture of the tooth, cystic degeneration, tumor formation, or reconstructive surgery, or the tooth is within the field of, let's say, it could be field of radiation or tumor resection. So in this case, there is definitive pathology. And in this case, yes, we can remove this tooth, but prophylactic removal of wisdom teeth is not recommended. Another most important indication for removal of wisdom teeth is recurrent pericoronitis. So if patient presented to you with recurrent pericoronitis, then this is an indication for removal of this wisdom tooth. But one episode of mild pericoronitis is not an indication. But if this first time pericoronitis was very severe, then you consider removing this wisdom tooth after signs and symptoms resolved. So this is an indication for extraction of wisdom tooth. But bottom line, for NICE guidance, prophylactic extraction of wisdom teeth is not recommended. If we move to North America and the American Association of Oral Maxillofacial Surgery or surgeon, they say that if tooth is symptomatic, that doesn't mean it's disease-free. We know some of periodontal disease, they don't have any, like, let's say, they're not apparent clinically, okay? It's a hidden disease there. So the statement by that helps here the clinician to decide whether to extract or not. They say that the third molar teeth that are associated with disease or at high risk of developing disease should be surgically managed. But in the absence of disease or significant risk of disease, active clinical radiographic surveillance is indicated. Okay, so in this case, if you have patient that doesn't have any disease around this wisdom tooth and not at high risk to develop a disease, then just leave the tooth in. Clinically is okay. Take an OPG, then take an OPG in 1 year time or 1.5 year or 2 year. Just keep the follow-up. So also here, they don't recommend prophylactic extraction of wisdom teeth. So you need to judge based on your experience, while this tooth may cause disease in the future or may not. Now, Very important thing when we talk about wisdom teeth, especially mandibular third molars or mandibular wisdom teeth impaction. We use a classification system to assess the degree of difficulty of removal of this wisdom teeth preoperatively before the surgery. And we use methodical examination ways in order to determine why this tooth is easy to be extracted or removed or difficult to be removed. The primary factor that determines the difficulty of third molar removal is accessibility. So if there is a good accessibility to that wisdom tooth, then it's easy to remove. If the accessibility is difficult, then it's difficult to remove. And this accessibility is determined by adjacent teeth and structure that impairing the access of the extraction delivery pathway. And we talk here about structures like ramus, like the cheek, like limited mouth opening. So they may affect the accessibility to this wisdom tooth. So with the careful classification of impacted teeth using a variety of systems, we can approach the proposed surgery in methodical fashion to predict whether to extract in normal way or extraordinary way, and if the patient will encounter certain post-operative problem. And to be honest, this is a hot topic nowadays because they start using the AI in order to predict the difficulty of extraction of removal of impacted wisdom teeth, and to predict post-operative complications, especially neuropathies of the inferior alveolar nerve after removal of wisdom teeth. But if you look at the old literature, mainly the classifications are based on the analysis of radiographs only. And in terms of radiographs, we mainly here talk about the OPG, which is the imaging of choice because it's available. However, in most countries now, it's not the gold standard for assessing wisdom teeth because they moved to the CBCT. OPG is available. You can, of course, assess the wisdom tooth, the adjacent structure, the relationship between the wisdom tooth and the inferior alveolar nerve. You can classify the wisdom tooth very easily. If you don't have OPG, sometimes intraoral periapical is adequate as long as it shows all parts of the impacted tooth and the surrounding structure. If not, then it's not acceptable. CBCT is the best, of course. It shows, of course, the exact relationship between the lower third molar and the inferior alveolar nerve and the exact spatial relationship of the lower third molar with the surrounding structure. Now, the most commonly used classification is based on the angulation. Okay, so it determined the angulation of the long axis of the impacted third molar with respect to the long axis of the adjacent second molar, and this was proposed, I think, in 1930s by Winter. So it's called it's called Winter classification. So in order to determine the relationship between the angulation of the long axis of the second molar and third molar, this tooth could be angled or it could have different angles. This could be angled, let's say, in distal direction, in mesial direction, in horizontal direction, in vertical direction, but also it may has different angles that not shown in the OPG that could be in lingual or buccal or palatal direction. However, this classification system is a useful tool to predict the difficulty, but it's not sufficient by itself to define the full difficulty of removal of wisdom tooth. Okay, based on this classification, you can have mesioangular impacted wisdom tooth where the crown is tilted toward the second molar in mesial direction. This is the most common type of impaction, around 43% of all impacted lower third molars. And it's the least difficult impaction to remove. And this is from your textbook. At the end of the lecture, I will maybe I disagree with this because based on my experience and other colleagues' experience, the difficulty orders based on this classification that mentioned in the textbooks may not be the right order. However, we have to refer to the textbooks because our reference for this course. So is the least difficult impaction to remove. Then we have the horizontal impaction where the lower third molar long axis is perpendicular to the adjacent second molar, as you can see here. So there is a 0 degree between them. It's more difficult to remove if you compare it to mesioangular impaction. However, only 3% of cases are horizontal impacted wisdom teeth. So it's not that common as mesioangular. We have then the vertical impacted wisdom tooth when the long axis of this tooth runs parallel to the long axis of the second molar. This is the second greatest frequency, 38% of the cases. It's considered third in ease of removal. Okay. Then we have the distoangular, where the long axis of the third molar is distally or posteriorly angled away from the second molar. This is uncommon also. Represents 6% of the cases of case of impacted third molars. It's the most difficult to remove. So the order here, we can say that the easiest to remove is the, sorry, we still have, okay. The easiest to remove is the mesioangular, then the horizontal, then the vertical, then the distoangular. And the reason why this is the most difficult to remove because of the withdrawal pathway of the of that tooth runs into the mandibular ramus. So here you need to remove more bone from the ramus in order to have this tooth out. Another important thing that may make this extraction difficult is that the mesial root of this impacted tooth is very close to the roots of the second molar. So there is a risk of damaging the roots of the second molar while removing the this distoangular impacted wisdom tooth. However, Winters didn't mention about the angles in angulation in other directions, which is the transverse impactions. So later on, they added these transverse impactions when the tooth is in horizontal position, but in buccolingual direction, not in mesiodistal direction. So the occlusal surface of the tooth is either facing the buccal side or the lingual side. In order to see exactly where this is in the buccal side or the lingual side, you can have CBCT or can request a occlusal radiograph to determine the buccal or lingual version accurately. It won't make that big difference. Once you open the flap and remove bone during the procedure, you will see immediately if whether this tooth is buccovergin or linguovergin impacted. Now, this is the, as I mentioned, when they added the bucco and palatal bucco and linguovergin impaction by Asher and Kruger. That was in 1984, added to the other angulations. Also, we have in number 7 here, as you can see, we call this is inverted impacted third molar. It's completely upside down. And number 6 is linguovergin, and number 5 is buccovergin. Number 4 is horizontal, number 3 vertical, 2 distoangular, and 1 is mesioangular. After that, Pill and Krugeri came with another classification, and this classification depends on the surrounding structure, not on the angulation. And the surrounding structures here are the anterior border of the ramus and the lower second molar. So they classify these impacted wisdom teeth based on the amount of bone covered, amount of tooth covered within the bone of the mandibular ascending ramus into 3 classifications. If there is sufficient space for this tooth to erupt, so the mesiodistal width of the crown is completely in front of the, or let's say anterior to the anterior border of the ramus, then this is a class 1. If the space is not sufficient and part of the crown is covered by the anterior border of the ramus or by the ramus bone, this is a class 2. If it's completely within the ramus bone and there is no space at all in the retromolar region for this tooth to erupt, then this is class 3. And the other adjacent structure, which is the adjacent lower second molar, and they compared the height of this impacted tooth with the height of the adjacent second molar. So if this impacted tooth, the occlusal surface at the level of the occlusal surface of the adjacent second molar, this is a class A. If it is below the occlusal surface of the adjacent second molar but above the cemento-enamel junction of the lower second molar, this is a class B. If it is below the cemento-enamel junction of the adjacent second molar, then this is a class C. So Pillay and Gregory classification has 9 categories of impacted third molar. Third molar could be class 1A, and this is the most easier to extract, or could be class 3C, which is the most difficult to extract. Here's an example here in the top left side. We can see here type 1A. At the bottom here, we have a type 2B and horizontal impaction. At the top here, it's vertical impaction. In the left hand and the right hand side here, we have type 3C distoangular. All difficulty factors are there. We have here Winter's line, also it's mentioned in the literature when you assess lower third molar for impaction, and it consists of 3 lines. The white line, of course, this line is used to determine the difficulty of the extraction of third molar. Winter line is a line drawn along the occlusal surface of the adjacent teeth, passing through the area of impacted tooth, as you can see, till the anterior border of the ramus. Then we have the amber line, which is from the anterior border of the ramus along the cemento-enamel junction, or the cemento-enamel junction of the adjacent teeth, which is the lower second and lower first molar. And we have the most important line here is the red line. It's a line that drawn from the amber line to the point of application at the tooth where the elevator should be placed to elevate this tooth. So if you look at the red line, the most important thing here about the red line is the depth of this, or the length of this red line. So as it determines the depth of this, let's say the depth of this wisdom tooth, or the amount of bone need to be removed. So for each 1 millimeter depth or length in the red line, there's 3 times increase in difficulty of extracting third molar. They say if the red line is bigger than 5 millimeter, then this is an indication for this third molar to be removed under general anesthetic or sedation. It's not recommended to remove this wisdom tooth under local anesthesia. If it's below 5 millimeter, then it's okay to remove under local anesthesia. So red lines indicates the surgical difficulty here. And as I mentioned earlier, it's perpendicular line to the point of application, from amber line to the point of application. In mesioangular, this point of application is mesially. In vertical impaction, it is, let's say, mid-buccal. In horizontal, it's also in the mesial side, but in the distoangular, it's in the distal point of application, not mesial point of application. Another important thing to look at it when you classify wisdom teeth or predict the difficulty of wisdom teeth extraction is to look at the root morphology, not only the angulation of the tooth or the relationship to the surrounding structure. So root morphology plays a major role in determining the degree of difficulty of the removal of impacted tooth. One important thing here is the length of the root. And we mentioned earlier that the optimal time to remove this impacted tooth is when the root is 1/3 to 2/3. Because if the entire length of the root develops, then there is a possibility to increase for distorted root morphology. This may lead to fracture of the root tip during extraction, or this root tip may impede the root delivery. So this Distorted root morphology will create difficulty later on. That's why root morphology is an important factor to consider when assessing wisdom teeth for difficulty of extraction. Also, if you look at the other side, if the root development is limited, less than 1/3 complete, then also it's difficult to remove this tooth because you can't have point of application to remove this tooth. It will be like a ball in the socket, or so it's gonna roll in its socket. Very difficult to remove. So this will prevent routine elevation. So complete nerve formation is not good, and less than 1/3 root formation also, it is not good for extraction. Here is an example here. If you look at the left-hand side, you can see this is less than 1/3 of root completion, root formation completion. So this is not advisable to extract. While here, if you look at the right-hand side, this is around 1/3, but not 2/3 completed root formation. So this create favorable extraction if you remove this tooth. Apart from root length, we need to look also at the a number of the roots and the direction of these roots. So roots could be fused in single roots or conical roots or separate and distinct. So if you look here in number A, this is fused roots, very easy to extract. Number B here, a club like roots, also it's easy to extract. Number C, distinct roots, but they are let's say favorable divergence or convergence. Here number D, it's diverted root. Distinct diverted roots creates difficulty, and the most difficult one is to have multi-rooted, not only 2 roots. Sometimes you have wisdom teeth with 3 or 4 roots and directed in different directions, and some of them are perforating the lingual plates. This will create difficulty during extraction and may damage the lingual nerve. So the curvature of the roots are very important, and the direction of this also root curvature is very important, because if you talk about mesioangular tooth and the roots are curved in distal direction, this is easier to extract. It's easy to extract because the curvature is the direction of path withdrawal. But if it's the root tips are mesially tilted or mesially curved in the mesioangular impacted tooth, this again is the path of withdrawal. So this may impede the extraction or the removal, or these root tips may fracture. Opposite applies for the distoangular. You can see here, for example, in the left-hand side, fused roots. So this make conical fused roots makes the extraction easier. In the left-hand side, you can see roots diverging in different direction, big roots, big distal roots. This create difficulty in extraction. Another thing in root morphology, you look at it, is the root surface area, and we mean here the root surface area of the lower wisdom in relation to the root surface area of the adjacent second molar. If the root surface area of the lower wisdom smaller than the root surface area of the adjacent second molar, as in picture A, this creates favorable extraction because you easily extract that small tooth while maintaining and not displacing the adjacent molar. If it's the vice versa, as in picture B, there is the risk of displacing this lower second molar. So if the lower second molar here, for example, has conical root, single root, there is a risk of displacing this tooth during extraction of the lower wisdom tooth. Another important thing is to look at the total width of the roots in mesiodistal direction, and this should be compared with the tooth with the mesiodistal width of the tooth at the cervical line. So if the mesiodistal width of the root is greater than the one at the cervical line, then this is a difficult one. You need to remove more bone. You need to section the root. But if the mesiodistal direction of the roots is smaller than the mesiodistal roots and of the width, at the cervical line, then this is easier extraction. Very important thing is to look at the periodontal ligament space. We know that the wider the PDL space, so easier to like save the tooth within the PDL space. So this will create more straightforward extraction. The opposite, if there's no periodontal space or the tooth is ankylosed, this will create difficulty. Also, the size of the follicular sacs or the follicle, the larger the follicle, the easier the extraction. That's because there is less bone to be removed, which make things or the tooth extraction more straightforward. And this is usually the scenario in young patient where they have large follicles around the tooth, so less bone need to be removed and the extraction will be easier. The density of the surrounding bone, we can't like the let's say interpret bone density accurately both in radiographs. This is not a reliable tool. However, the best predictable or predictive factor for to predict the bone density is the patient's age. We know the younger patient, the softer the bone, the flexible the bone, the easier the extraction. The older the patient, the more dense calcified the bone is, then the difficult the extraction. Also, usually in males, more bone density, difficult extraction. In females, the bone is less dense, the extraction is easier. By the way, for the impaction of wisdom teeth, they found that's more common in females than male. And the eruption of wisdom tooth is 3 to 6 months earlier in males than females. Another very important thing to look at it when you assess difficulty of extracting wisdom teeth is the contact with the mandibular second molar. If there is enough space or enough bone, good bone between the second molar and the impacted third molar, this is more straightforward extraction because it's less likely to care about this second molar to damage this second molar. But if the roots, like for this triangular extraction impacted tooth, the mesial root of the impacted tooth is very close to the lower second molar, you need to be careful not to damage the lower second molar. So this is difficult extraction. Same scenario if the second molar has caries or large restoration or endodontically treated, then sometimes there is a chance to displace this large restoration or this crown or fracture the root. So this will create a difficulty. Another important thing to assess when you look at the X-ray, when you're assessing lower impacted third molar for extraction, is the relationship of the roots of this impacted tooth to the inferior alveolar nerve. Usually, you will see this inferior alveolar canal or inferior dental canal superimpose this, or the roots superimpose the inferior alveolar canal on the radiograph. In reality, the canal is in the buccal aspect of the tooth, and you can't, of course, localize it accurately based on the OPG. You need to have CBCT for that. But if you go back to the famous classification of the relationship of the inferior alveolar nerve to wisdom tooth by Rood and Shihab in 1990, they classified the relationship of, let's say, they identified 7 radiographic signs that may tell that this wisdom tooth may have an impact on the inferior alveolar nerve or may damage the inferior alveolar nerve if you extract it. These signs, 4 of them are for the root themselves and 3 for the canal. If you look at the roots, one of the signs is darkening of the roots. The other one is deflection of the roots, narrowing of the roots, darkening and buffed apex of the root. While for the canal, there are 3 radiographic signs that tells that there is an intimacy, or let's say an intimate relationship between the third molar and the ID canal, like interruption of the white lines of the canal, we call them tram lines, diversion of the canal, or narrowing of the canal. However, once CBCT starts to be like used commonly in research and clinical practice, they found that only 3 signs from these 7 signs are, let's say, have positive predictive value for inferior alveolar nerve injury after third molar surgery. And these signs are the darkening of the roots, deflection of the roots, and diversion of the canal, while the other signs had low, let's say, positive predictive value. However, if you look at the OPG is good in excluding the relationship, so it has high specificity but low sensitivity. So it's good in excluding the relationship, but not the proving the real relationship between the inferior alveolar nerve and the canal. Now, what are these relationships of inferior alveolar nerve to the roots? If you look at the tram lines on the radiograph, you can see the tram lines continuous, not affected, going through the roots. This is superimposition. The canal could be either buccal or lingual, okay? That's in case the canal is superimposing the roots, but majority of case you'll see that the canal is below the roots, okay? So here, the canal is superimposing the roots in A. If, let's say, one of the tram line is lost, okay, while crossing the root surface, this could indicate light grooving or light notching of the ID canal on the root surface. If the canal is at the apical part of the tooth here, or the root, sorry, and one of the lines is discontinued, this could indicate apical notching from the canal into the root. If both lines are discontinued, this is could be deep grooving or deep notching. So if you mobilize the tooth too many times, you may hit the nerve, compress the nerve, and cause nerve injury. Same applies for the light notch or light groove. In case of D, where you have discontinuation of both tram lines and narrowing of the canal, this may indicate perforation of the roots. So the ID canal, as you can see here in this example, perforating the roots, and you need to consider alternative options rather than extracting of this tooth. We're going to talk about these options in our next lecture. So this is the relationship of the inferior alveolar nerve with the roots. Of course, in order to determine this relationship accurately, you need to have CBCT. Another famous classification, and this is the classification that we use or used by most dental insurance, and we companies, and we use it also when we charge patient for extraction of wisdom teeth in our private clinics, is the nature of overlying tissues. So we classify them, or classify this impacted wisdom tooth in three categories: either soft tissue impacted, or partially bony impacted, or fully bony impacted. Soft tissue impacted, of course, fees will be, or the cost of extraction will be cheaper compared to the other types. The fully bony will be the most expensive one. So this is the what the dental insurance company, let's say, the chart that they use to charge patients, or when they communicate with the operating surgeon. Now, this is just these two boxes, just to summarize the factors that make extraction of third molar, the lower third molar here, less difficult or more difficult, based on the classification we mentioned earlier in the radiograph. And these are tooth factors, and let's say tooth and surrounding structures, because we have also other difficulty factors that you need to consider related to the patient, not to the tooth. So these are all the classifications, but the most famous classifications. However, in most recent years, let's say in 2013, surgeons from Lithuania came up with this classification to predict the difficulty of the wisdom teeth extraction, and it's the most accurate so far. It's modified also in 2021 by another surgeons at Medical University in Vienna. And if you look here, when they classify wisdom teeth, they classify it based on 1, 2, 3, 4, 5, 6 criteria. Okay, first criteria is based in the mesiodistal position of this tooth in relation to the second molar and in relation to the ramus. As you can see here, we have 4 categories. Each category will be scored from 0 to 3. 0 means conventional extraction, while 3 means complicated extraction. Okay, for the first category, we have two factors here, the relationship to the second molar and the relation to the mandibular ramus. Then we have the apicoronal position in relation to the alveolar crest and in relation to the inferior alveolar nerve, which is the injury risk. As you can see here, we then have another 4 categories. And then we have a relationship to the lingual and buccal wall, which is the buccolingual position of the tooth. This will tell you about the risk of the lingual nerve injury. And then we have the spatial position, okay, of that tooth, which is vertical, whether it's vertical, mesioangular, distoangular, horizontal. And the way they use this classification, if the tooth scores all 0, then that means it's a conventional extraction. If the tooth has at least one category with score 1, then this is a simple surgical extraction. If it's had at least one category with score 2, then this is moderate surgical extraction. If it has one category with score 3, then this is complicated extraction. So it's modified in 2021, and they add to it also the curving of the roots, as you can see here in the left-hand side, either incomplete root formation, or less than 1/3, or complete root formation, which is favorable, or complete root formation, which is not advantageous or not favorable. The roots are directing in opposite direction, different direction. While the others one are the same for the classification that we mentioned earlier, the ramus relationship, molar relationship, retention depth, and angulation, and the nerve relationship. So let's take this practical example for this tooth. We have our OPG, and based on this classification, you can find that this tooth is called M1, R1, A2, C2, B1, S3. So as you can see here, because this tooth is score 3 in one of the categories, then this makes this tooth complicated category if you want to surgically remove it. And it's score 3 here because it's horizontal impacted. Because as I mentioned earlier, I disagree with all the classification where they mentioned that the most difficult extraction is the distoangular, then the mesioangular, then the vertical, then the horizontal, then the easiest one is the mesioangular, and the most difficult is distoangular. Here, the easiest one is the vertical to extract, while the most difficult one is the horizontal or inverted to extract. And that's actually more realistic. Okay, the other factors that you need to consider, apart from tooth factor, are the patient's factor. They are very important factors. Cooperation. If you have uncooperative patient and it is very easy, simple extraction, this is a complicated extraction. This will make extraction very difficult. So cooperation is very important, and cooperation will the most important factor that will tell you about the best setting for doing this extraction, whether to do this extraction under local anesthesia or under local anesthesia with sedation, conscious sedation, deep sedation, or just to put patient to sleep and do the extraction. Age of the patient, we mentioned earlier, the elder the patient, the difficult the extraction, the more post-operative complications, the poor prognosis of nerve injury healing, if nerve injury happened, the delayed healing. Ethnicity, because if you look at the people from African origin or Black people, they have very dense bone. This makes the extraction difficult, and sometimes you may fracture the jawbone while you're trying to mobilize the root because the bone is very dense. Mouth opening is very important factor because here, if patient has limited mouth opening, accessibility to this wisdom tooth is very difficult. Then this put this wisdom tooth extraction at the difficult level. BMI, very important also to consider. The more obese the patient, the more difficult the extraction. And again, this is related to the accessibility to the lower wisdom tooth. We know that these patients with high BMI, they have a very large tongue, very, let's say, enlarged buccal mucosa. So make the accessibility very difficult for these patients. Of course, you can add to these patients factor, patients' medical problems. If patients suffer from diabetes, if patient is a smoker, this may affect your local anesthesia, may affect postoperative complications too. Now, let's move quickly here, move on to the maxillary third molars. So when we classify maxillary molar third molar impaction, same classification. I mean a classification based on the angle of impaction. So we have vertical impaction, which is 63% of the cases, then distoangular impaction, then mesioangular impaction. We also have other positions, but very rare, like transverse position, inverted horizontal position. But the most common one, again, is the vertical impaction. Here's the classification of upper third molar impaction by Archer. You can see here, number one, we have the vertical impaction. Number two, mesioangular impaction. Number two is distoangular. Number three, vertical. Number four, horizontal. Number five, buccoverging impaction. Number six, palatoverging impaction. And number seven, inverted impaction. Also, Archer classified the impacted maxillary wisdom teeth depends on the depth here in relation to the adjacent second molar. And number A, as you can see here, at the same occlusal level. So it's not impacted anymore. It could be only soft tissue impacted, not bony impacted. Number B, below the occlusal level, above the cement to enamel junction. Number C, below cement to enamel junction. Number D, at the apical third of the roots. And number E here, as you can see here, below the roots or above the roots, let's say, to be more accurate, above the roots of the adjacent second molar. The difficulty of removal here differ from the one for the impacted lower third molars. As you see here, the vertical and distoangular are the less complex to remove, whereas the mesioangular are the most difficult to remove. The reason here of this difficulty or the mesioangular impaction, because for mesioangular impaction, you need to remove more bone, more overlying bone to access the tooth. So it's create a little bit of difficulty. While for the distoangular, usually the overlying bone is thin, very easy to put your elevator at mesial point of application and just elevate the tooth distally. While the mesioangular, you need to remove a bit more bone in order to remove. And this will make more, what make things also more difficult if the tooth is lying more palatally than buccally. So what are the factors here that we need to consider when you're assessing upper third molar for extraction? Of course, the most important factor is the buccopalatal direction here. Okay, this is very important because this will tell you amount of bone that you need to remove. The more the buccal direction, the less bone you need to remove. The more the palatal direction, the more bone you need to remove. Another important factor here that you need to look at it when you assess difficulty of extraction upper third molar is the roots of the third molars, because usually upper third molars have thin non-fused roots with erratic curvature. So as you can see here, every root is directed in different direction. Those will create difficulty. So the root morphology is very important to assess. Again, PDL space width, follicle bone density, relationship to the adjacent second molar, overlying tissues, same for the lower third molar. We add here another two things you need to assess that not present in the mandible, which is the maxillary sinus. The proximity of the roots to the maxillary sinus and the risk of oroantral communication after extraction of this tooth need to be assessed. The more the divergence the root, the more the, let's say, the longer the root, the more divergent the root, the more the risk of creating oroantral communication. Same things for tuberosity fracture. You need to assess for tuberosity area. If there is a dense bone surrounding the tooth, if the roots are divergent in different directions, when the tooth is mesioangular, angular or you have pneumatized sinus and large sinus and you use excessive force, all these factors predisposed to tuberosity fracture. So you need to assess these factors carefully. And of course, after tuberosity fracture, you may have also oroantral communication. Of course, upper wisdom teeth could be also classified based on the type of overlying tissues, while they are whether they are soft tissue impacted, partial bony, or fully bony impacted. Okay, we come to the end of this lecture. Do you have any questions? Okay, so thanks for listening. See you next week, inshallah, in the second part of this topic. Have a good night.